Howdy! I'm live again. Howdy, everyone. It's Aaron Boster, and thanks for learning about MS with me. Last night, I, in sort of an impromptu fashion, jumped online, and I was overwhelmed by how much fun I had and how many people ran out to join me. We had 150 some people all online by the end of an hour, answering questions and talking about MS. This is MS Awareness Month. My kids are in bed, and I thought, what the hey, we might as well jump online and see what happens. So I decided to do it again and have another evening time MS Q&A. I have no idea how many people are going to come out or if anyone will come out at all, but I really wanted to give it a try. I was very curious about the time of day. So thus far, there's one person online with me. As you jump online, do me a kind favor. Tell me where you're calling in from. I love, as this online community grows, to see where everyone's calling in from. It's awesome. Also, please keep in mind that I can't, I'm just typing howdy. Hey, Matt, what's up? I can't diagnose an individual. Matt, it's just you and me online. There's some more people joining us. It's awesome. Matt, I thought I would do it again. I thought that I would jump online and do a Q&A. You know, it's MS Awareness Month. My kids are in bed, and I thought this is a great time. We might as well see if everyone's interested in the evenings like last night. I've got Sonia online. Hello, howdy, hi. Cassie's here. Hello. Gary, hello. Matha, how are you? Divine, great to see you. Matt, it's good, of course, to see you, my friend. Michelle Charles, how are you? April, howdy. This is really great. We've got 53 people that have jumped online. If you like this idea, maybe this is something we can keep going at a high frequency for the month of March, for MS Awareness Month. So if you like that idea, you don't think it's a bit overwhelming, give me some thumbs up. We'll do thumbs up tonight if you like the idea of some evening chats throughout the month of March, MS Awareness Month. Hello, everyone. Now, as you jump online, please share with me where you're coming from. We've got Brad from the Gold Coast of Australia. That's kind of awesome. Australia is certainly in my bucket list of a place I'd like to travel to. Let's start with some questions. Questions or topics. Again, please keep them general. They should be about neuroimmunology and MS. You know, I can't do love or politics. I can't do, sports. But if it's about MS or a related condition, I should be able to field the question. I am loving these thumbs up. This is awesome. Click the thumbs up button at the bottom of your screen, and it'll keep a running tally. So who's going to throw out the first question tonight? Hello from Columbus, Ohio. Hello, Maggie May. It's good to see you. There's a lot of great people. Hello, Melissa Green. So who's going to ask the first MS-related question? Here we go. So Michelle Charles writes, is it normal to experience weakness and have legs shaky when descending downstairs? Also jolts in the arms, hands, etc. So that's a great question. Now, sometimes people think about really challenging themselves going upstairs. And when you're going upstairs, you're using certain muscles to propel you up. So the muscles of the tush that extend your leg and the quadriceps, you're really pushing hard. When you go downstairs, you actually focus on different sets of muscles. So the backs of the legs, the hamstrings become very important. And some people find that because of where they're weak or where they're stiff, going downstairs is actually much more challenging. It's not uncommon that I hear people tell me they really notice the weakness when they're trying to go down steps. And when you realize there's different sets of muscles that are being focused on, I hope that makes sense. That was a great question. I'm going to keep reading. Is stomach pain normal in MS? I don't think that stomach pain is a common symptom in MS, but I certainly hear about it. I wouldn't, if you had a stomach pain, my first thought wouldn't be this is an MS symptom. I would be looking for other things in the belly that might be causing pain. It's not something that I would ignore. And of course, any of these symptoms you want to bring up to your own provider so that they can help out. I've got 54 people online. This is really fun, guys. Let's look and see what else is going on. I got Shane from Akron. How are you, my friend? Here's another question. So April writes, I noticed after my last infusion, my eye stopped twitching, but it's back to twitching for the past month. Is this normal? Now, April's describing a chronic symptom, eye twitching, that was there for a while, and then it went away following an infusion. And then it's come back after a while. And I'm going to make an assumption, April, that you're talking about an infusion of one of the monoclonal antibodies for MS, Tysabri or Ocrevus or Lemtrada. Or you may be talking about IV steroids, but I'm going to guess that you're talking about those products. And it is not uncommon, particularly I've had the experience where we give someone either Ocrevus with steroids or Lemtrada, and for a period of time, old symptoms seem to die down or go away. Now, that's unusual, but my only explanation is they must have had some active smoldering inflammation. And when you use a really, really potent anti-inflammatory, this inflammation goes away. And then over time, it could come back. And I want to give you guys an example. A wonderful patient I take care of was very, very distraught because of Lhermitte's. And so when he would bend his neck down, he'd have electric shocks down into his feet. And it was so painful that he oftentimes would kind of move sort of like a Frankenstein, not moving his neck because it would hurt if he moved his neck. And every time he saw me, he wanted me to make it go away, or oftentimes he'd ask me to make it go away. And I show him his lesion on the back of his spinal cord, and I tell him, I can treat symptoms, I can give you medicine to make the discomfort go away, but I can't make it go away. So he had this for 7 some years. And then we gave him one of these really potent anti-inflammatory disease-modifying therapies, one of these highly potent or highly effective DMTs. And he came back to see me about a month or 3 months later, and he said, "You're a liar. You told me that would never go away, and it's gone. And I can do this, and nothing happens." And I said, "You're right. I'm a liar. I didn't mean to be a liar, but I can't believe that disappeared." And I think it's stayed away except for rare exceptions. And it's now been a couple years. The only way I can explain that, knowing that he's got this giant lesion in the back of his neck, is to assume that there was still active smoldering inflammation and that we quelled that inflammation. So I hope that helps address your question. It's kind of a long-winded answer. There's 90 people online. This is freaking awesome. All right, let's keep going. Let's see. I'm trying, of course, guys, to do the best job I can reading. If I skip your question, it's not on purpose. All righty. What else do we got? Question about the MS hug. So Bluth Don writes in, would putting physical weight on body and removing it help mentally, like mirrors or phantom pain? So I have not seen something like that to be helpful with an MS hug. You guys keep in mind the MS hug, which I have a couple videos on MS hug, and I'll try to leave descriptions down below in the post when I do this. But to talk about it right now, the MS hug is a horrible sensation where you feel squeezed. And people describe it like a belt wrapped around their torso, being pulled on tight, or something like that. And what's really happening is the spinal cord is short-circuiting because of an MS lesion or plaque. And it's sending a fake message around the nerves around the waist and the rib meat, if you will. So the meat between the ribs, that's muscle, and it contracts and it causes a squeezing sensation, and it can be absolutely horrible. And so he's asking about ways of trying to make it better. Now, I use commonly medicines to make it better. We use medicines like baclofen, we use anti-seizure medicines, and those can be very effective in quelling down the inflammation. My partner at times will do Botox, actually. You have to be really careful doing Botox in this area because you don't want to paralyze the diaphragm underneath it. But if you poison the muscles, you can get them so they don't contract. I'm not familiar with adding weights to the body to make it better. Now, if someone has experience with that, please type in the comments below because I like to read about it. Great question. So Shane Greenland writes, what form of cannabis is best for neuropathy and muscle spasms? Shane, that's a fantastic question. And there's been some research done looking at cannabinoids. Cannabis is an example, in MS spasticity. Now, interestingly, they almost haven't at all studied combusted smoked cannabis. So when you talk about like a joint that you light and then smoke, there really isn't any solid research studying smoked cannabis in spasticity. There's also very little research on edible cannabis in MS spasticity. The bulk of the research has been done on an oral mucosal spray. So think of like a breath spray that would spray in your mouth, except each spray delivers 2.5 milligrams of THC and 2.7 milligrams of CBD. It's a extract from the sativa plant, and it's called I'm trying to think of the trade name, Sativex, but I can't think of the long name. But Sativex is the brand name, and it's not available in the United States. It's available in Canada. It's available in the UK. So to tell you the answer, all I can say is there's not a lot of data at all to support benefit with smoking combusted cannabis or with eating it. There needs to be more research. Now, the reason this is important is most people consume cannabis through one of those means, and we have a paucity of research. I hope that answers your question. There's 100 people online. That's awesome. I'm having a great time. If you guys are, give a thumbs up down below. So William Rice writes, how common is shingles with MS? I've had it a lot in dealing with MS. So shingles is from a virus called the varicella virus. And we see varicella breakthrough sometimes with some of the MS medicines. If you really suppress the immune response and you have been exposed to chickenpox never goes away, it can reemerge. And I wouldn't say that MS and shingles are closely linked, but I do see an increased incidence with some of the MS medications. Shingles is extremely painful. And as soon as you start to notice spots or pain or vesicles, you want to bring that to the attention of your provider. The faster you get on a medicine called acyclovir or one of the derivatives of acyclovir, the faster we can make that pain go away. There's one medicine in particular, alemtuzumab, Lemtrada. And because there's a slight increased risk of having shingles or herpetic outbreaks, we actually give people acyclovir. And we keep them on acyclovir after Lemtrada for months at a time to suppress that risk. So I hope that answers your question. Cindy Roper asks, is there a study for the ocular nerve regeneration? And I'm not particularly aware of the product that she's talking about. So I apologize. I'm not going to be able to answer that question. So Kyle writes in, I had a large flare after my second round of Lemtrada in early November. So that stinks. I'm currently in PT for nystagmus and strengthening. I have no notable physical disability and want to return to working out. So I'm not sure about the question there, Kyle. This is a journey. And one of the commonalities in MS is that sometimes you get surprises, and not surprises like a present. You can get new neurological deficits. I think in part that's why this can be a really challenging thing to deal with. And as I talk to people with MS, they share that with me. That waking up and not being sure if everything's working is very, very difficult. Here we have a person who's going through highly effective therapy. And right after the second round of Lemtrada, they had an attack. And quite honestly, that stinks. Now, a couple quick comments. That doesn't mean the Lemtrada failed. I know that sounds weird, but we've studied this. And just because you need another round of Lemtrada or have an attack while you're on Lemtrada does not predict failure when you look 7 and 8 years out. So I like to remind people of that so that they don't become disheartened. The second thing is that you can bounce back from an attack. And this is an example of someone who's working really hard doing physical therapy. I'm going to make an assumption that they may have been treated for this attack, and the goal is to recover. It takes a tremendous amount of fortitude. And I'll end just by saying I'm continually impressed with people struggling with this condition. It's impressive to watch, and I'm honored to participate in that kind of experience. All right, enough said about that. Let's keep moving along. So Keith says, hi from Michigan Infusion tomorrow. Keith, we're going to be thinking about you. Matt points out that it's a marathon, not a sprint, and you're absolutely right. And a lot of times I'm trying to remind people of that. When you're having an attack or when you're losing function, it's fair to grieve and it's fair to be sad about that. But then we have to dust ourselves off and say, okay, well, now what? And that can be tough. All right, what else do we have going on right now? I've got people saying hello from Nicaragua. That's awesome. Hello. Rotten said, all right, I'm a 54-year-old male. I'm not going to do individual things. So I'm looking for a question here. So Stephen Craver writes in, can an RR relapse last years? So he asks, can a relapse last years? And the answer is no, but it can seem like it. And let me explain this to you. A relapse is clinical disease activity. And we believe that a relapse is caused by naughty autoreactive cells in the bloodstream crossing the blood-brain barrier into the brain, and then seeing a part of your brain and thinking that it's looking at a foreign invader and attacking it and causing a focal area of inflammation. Now, that inflammation essentially short circuits out that part of the brain. And so let's say, for the example, that it's the optic nerve. And so it damages the optic nerve. And as a result, you can't see very well out of that eye, and it hurts when you move it. Now, the inflammation will eventually die down and it'll go away. And after that, there can be a return of function. Sometimes after a relapse, you have 100% return of function. But sometimes after relapse, you're left with some deficit. Maybe the optic nerve is 50% permanently damaged. So in this example, the relapse, typically when we study this, lasts a couple weeks in duration. But the impact, the residual impact from the deficit, can last the rest of your life. And to the human being, you don't experience, this is an acute relapse, this is the long-term sequelae of damage. You experience, my eye doesn't work and it's still not working. And so that can feel like you're having relapse symptoms that go on forever. I have a video that talks about relapses, in a separate video where I talk about progression. And progression also can sometimes be confused with a really long relapse. And so let me just talk about that for a brief second. By the way, there's 115 people online. This is really freaking cool, and thank you all. It means a lot to me that we can talk like this, and it's particularly cool as we celebrate MS awareness. Now, I'm talking about progression for just a couple seconds. Now, the way that I like to think about progression is the way that Stephen Krieger teaches it, talking about the leaky pool model. And so if you're not familiar with the leaky pool, write a comment, and maybe that's something we can discuss in an upcoming video. But progression really is predicated on previous damage. And now let's give an example where someone has an attack in their spinal cord and their right leg goes numb and gets weak. And they get steroids and then they do rehab and they recover. So their leg function is back to normal or near normal. Now fast forward 15 years into the future. This whole time, their spinal cord structurally has been damaged. And that area of structural damage starts to wear out. As the human ages, as the spinal cord ages, that area of previous damage can start to wear out. And the old residual leg symptoms can slowly start to come back. And in fact, as the area wears out, maybe the other leg becomes affected. And it's the reemergence of old neurological injury in the absence of attack is one of the ways that I like to try to help people understand progression. In both examples, the attack where you didn't fully recover, or in the progression, it can give the sense that you're having an attack that doesn't stop. So, Stephen, I hope that answers your question. All right, moving right along. Looking for another question. So Kelly writes, good evening, doctor. Wow, 2 nights in a row. Question. What are the differences between white lesions and black holes? That's a great question. Now, there's a couple videos in the MRI playlist on this topic. So I want to answer your question, but if you want to hear more about it, certainly go and check that out. When you get an MRI, you'll see bright spots. There's typically 3 colors of spots. There's glowing bright spots, the enhancing lesions. And the enhancement this particular technique brings out the new lesions, new like now. So what we do is we inject dye into your vein and it floats around the bloodstream, including the blood vessels of the brain. And if there's breakdown of the blood-brain barrier because of inflammation, because of a new lesion, then the dye leaks out temporarily into the brain tissue and it lights up. It's called an enhancing lesion. And that'll be literally like a glowing bright spot. Now, then there's the white spots, and these are called T2 lesions, and that's technical stuff that doesn't really matter for this conversation. But when you look at the MRI, you see these white spots, and those white spots mark areas where there's been inflammation. They don't tell you anything about how old they are. They could be brand new or they could have been there since birth. They're going to show up as a white spot. When you get a scan and then a year later get a second scan, we're looking to see if there's enhancing lesions, which tells us that there's a lesion now. But in my opinion, more importantly, or equally as important, we put a last year's scan and this year's scan, and we compare side by side each lesion. And if we see a lesion, a white spot in this year's scan that we didn't see in last year's scan, we know it's new. We know it's new as of last year. And so in the last year, you have a new spot. And if you're taking an MS medicine and have a new spot, that's called breakthrough disease. And so that's bad for you. Those are the white spots. The dark spots tell you something different. So we've talked about enhancing lesions. We've talked about white spots, the T2 bright spots. And now I want to talk about the dark spots, which we call black holes. Now, the technical name is a T1 hypointensity, but it's a hole. Quite literally, pathologically, it's not showing you inflammation. It's showing you an area where there's no longer any tissue. Now, the way that I like to conceptually think about this is a war zone where there's a big war going on and there's blasts and guns and bombs. And when all the dust settles, the war was so intense that it destroyed all the buildings and there's nothing left there. It's just a field. And if you think about the inflammation in one of the bright spots, the white spots, if the inflammation is intense enough, when it dies down, it's actually destroyed the tissue underneath. And that'll show up as a T1 black hole or a dark spot. Now, it turns out that the black holes correlate better with long-term disability. And so when you go to see your MS neurologist and they get an MRI, I think you should ask to see it. I think it's helpful to visualize your scan. And you want to have a conversation with your doctor and say, hey, do I have any enhancing lesions? And you should be able to look at it with them and see if you have any enhancing lesions. You also want to ask, do I have any new bright spots, or do I have any bright spots that have gotten larger? Because a spot that gets larger is the same thing as a new spot. It's bad. But then the third thing you want to ask is, do I have any new dark spots? Do I have any new black holes? Now, the fourth thing that you want to look at with the MRI, since we're talking about this, is whether there's any accelerated brain shrinkage. Does my brain look like it's smaller than it did last year? Now, where I work at Ohio Health, we use some pretty fancy software to figure this out, but there's a poor man's way to do it. And it's actually measuring a structure in the middle of the brain called the third ventricle. And so we can measure it, and then we can see if it gets bigger over time. And if it's getting larger and larger, that tells you that there's accelerated brain shrinkage. And so those are the things you want to ask about on an MRI. The enhancing spots, so that's the glowing, bright gadolinium enhanced spots. That's the contrast. Number two are the bright spots, so new or enlarged T2 spots. Number three, which is this initial question, was the dark spots or the black holes. And the fourth thing is if there's evidence of atrophy. Awesome question. Thank you very much. All right, what else do we got here? Daryl. So I need an MRI with contrast. I had no contrast MRI last year. Will that indicate, let's see. Oh, I skipped, I lost the question. All right. So here, he writes, so I had an MRI with contrast, question mark. I had a no contrast MRI last year, showed grossly unremarkable scan. Okay. So Daryl's asking, do I have to get an MRI with contrast? And I want to talk through that. Now, of course, I have a video on this topic as well. And the discussion is really, what if I don't get the contrast? If I don't want it for whatever reason, what happens? Well, you don't learn all the information. I would submit that you learn maybe 80% of the information, but you're missing some of the important stuff. When we see an enhancing lesion, it changes management. So it's a really big deal. And if you don't get contrast, we can't learn that. So I don't think the scan is useless without contrast, but I think it's much more useful if you get it with contrast. It is always my opinion that it's better to get it with contrast because I want to learn as much as possible. There's some concerns about contrast, and one of them is if it could damage the kidneys. And before we obtain an MRI where I work, we always get a kidney test, a blood test, to make sure that the kidney function is normal. And so if you have that concern, it's an easy blood test to have your kidneys checked. The second concern I sometimes hear is that, hey, I heard by Chuck Norris and by other people on the internet that you can have the gadolinium contrast dye stay in your brain and it'll get stuck there. And that's not true with the new contrast agents. The newer contrast agents are called macrocyclic molecules. So macro, big, cyclic, circle, macrocyclic molecules. And macrocyclic contrast agents do not get stuck in the brain at all, zero. Linear contrast agents, which are the old kind that aren't really used anymore, can. And so if you're concerned about that, you can say, hey, are you guys using macrocyclic molecules? And they'll say yes in the United States, because I don't know of any places that still use linear molecules. Anyways, I hope that answers your question. All right, let's look for another question. L. Holly writes, after 1 year on Ocrevus, if the neuro sees a new lesion activity on the MRI, is that an indication to change or come off that drug? L. Holly, that's a great question. So she's saying, after I've been on a disease-modifying therapy for 1 year, if we get an MRI and see a new spot, is that a reason to switch drugs? Sorry, guys, I can't hold my water. And so I love that question. Now, she specifically asks about Ocrevus, but really, you can have the conversation with any of the disease-modifying therapies. Here's what I would say. If you're taking birth control and you get pregnant, it didn't work. Because the goal of birth control is that you don't get pregnant. And so if you're on a disease-modifying therapy and you have a new spot, that's not the goal. But the difference between birth control and the disease-modifying therapies, birth control is like 99.9% effective. It's really, really unlikely if you take it correctly that you're going to get pregnant. Whereas the very best MS medicines we have are nowhere near that. And so if you have a zero tolerance policy, then you arguably might cycle off of a drug too soon. Here are some thoughts. If you have a new spot on Ocrevus in the first 6 months, you can't decide yet that it failed. When you look at the clinical trial data, Ocrevus shuts down the MRI really well, but it takes more than 6 months to do a great job with it. At 6 months, it hasn't achieved full suppression. So if I put someone on an MS medicine, I like to check my first MRI at 6 months. If it looks clean, yay, that's my new baseline. But if I see that there's a new spot, I don't take them off the drug yet. I get a scan 6 months later. If this one looks clean, I keep them on drug. But if this one shows a new spot also, now I have a pattern. I had a new spot at 6 months. I now have a new spot at 1 year. Then I switch drugs. So I apply the same logic when I'm looking at the Ocrevus here. If you started Ocrevus, or talk about a different disease-modifying therapy, and you're not getting a scan for a year, let's say that's the first time you're getting a scan, and you see a new spot, you don't know when it occurred. It could have occurred before they started the Ocrevus, if it's been that long since you got a scan. It could have been the day after they started, and you don't really know. And so that's why I like to get my first scan at 6 months. I feel like I kind of saved some time. If I got my first scan in a year and I had one new spot and the person was otherwise doing really well, we would talk about it. And we might not decide to throw Ocrevus out. We might decide to give it one more chance. And in my clinic, we'd probably check an MRI 6 months later. So I hope that answers your question. Any breakthrough disease is bad for you, but you have to put it in context and you have to understand how long it takes the drug to start working. Think about this. If you had a terrible headache and you put an aspirin in your mouth and counted to 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and your head still hurt, you couldn't say the aspirin wasn't working. Because in this example, it takes longer than 10 seconds for aspirin to start working. In the same fashion, there's a therapeutic lag. There's a lag in the benefit of the therapy when you're taking these disease-modifying therapies. In my experience, the fastest therapies are starting to have some benefit at 3 to 6 months, but that doesn't mean that they manifest the full benefit they're going to have. It's not an easy, quick answer because I think there's a lot of context that we have to consider, but I certainly hope that helps. Okay, let's look for some more questions. So Matt D says, is Ocrevus just as effective for PBMs and RMS? Well, Matt, we're looking at different things. In PBMS, people typically don't have attacks. And we saw that we slowed down the accumulation of disability by 25%, which I think is awesome. And we slowed down new brain shrinkage by 18%, which I also think is awesome. And with PBMS, we saw that Ocrevus increased the likelihood of having 3 months of quiet by 50%, which is awesome. But those aren't exactly the same exact things that you're looking for in relapsing MS. In relapsing MS, the biggest effect was cleaning up new spots on the MRI and on relapse rate. And so I don't know if you can say it worked better or worse. I think they're very different disease states with different presentations, and the drug was trying to accomplish different goals. I'll point out that it did very well in relapsing MS and also did very well in primary progressive MS. And that's why it's the only FDA-approved therapy for PPMS, which I think is a godsend. So Kim Ball writes, my last visit to the neuro, they took blood to check for liver functions due to disease-modifying therapy. It was dangerously high. Then I got a letter from my neuro saying it was due to excessive alcohol. I was livid because I don't drink. So there's a lot to talk about in that question. So first of all, when you're on a medicine, any medicine, it's important to know if you need safety laboratories. So a lot of medicines require you to check laboratories to make sure that the medicine's not hurting your body. And so this is true with a lot of the disease-modifying therapies. In fact, most of the disease-modifying therapies require that we check certain laboratories, such as blood counts and liver enzymes. Why liver enzymes? Because a lot of drugs are processed or metabolized in your liver. And so you want to check to make sure it's not being too hard on the liver. And if you get liver enzymes that are elevated, it can warn you that your liver is being damaged or at risk of being damaged, and you can link that to a medicine. So the first thing I'll say is it's good that you're having liver enzymes checked if that's a medicine that requires that kind of observation. Now, the second part of the question is this comment where she got a letter saying, oh, it's from alcohol. Well, I think that we have to be thoughtful, and I think we have to consider every option of things that could be damaging your liver. So if someone consumed alcohol, it's possible that could damage their liver, and so we want to contemplate that. And if they're taking Tylenol, it can damage their liver. And if they're taking a anti-seizure medicine, it could damage their liver. And if they're taking a certain MS medicine, it could. So I think that we have to think across the board at all the various options. There's even certain types of vitamins at very high doses that can damage the liver. And so these are all things that we need to be thinking about. If I got a letter like that, I would probably be upset also. That would make me feel bad. And I would certainly bring it to the attention of my provider and say, hey, look, I don't drink. And you've got to help me find a different answer. Good question. So I have a question here. In a few months, I'm a few months after the first round of Lemtrada, and I feel like my symptoms are going haywire. It wasn't like that when I first started. Is this normal? Well, I don't think that's normal, and I think it's noteworthy. I would definitely talk to my MS provider about it. People can have an uptick of symptoms for lots of different reasons. For example, sometimes the patient will come in and they'll have worsening of their baseline symptoms, or their symptoms are haywire. And we check and find out that they're having a urinary tract infection. And we treat the urinary tract infection and they feel better. Or we may find out they have another type of infection, or they may have something else going on. My point is we start to go searching for what could cause that. They could be having an MS attack, but the human being doesn't know this is because of a urinary tract infection, or this is because of an attack, or I have a symptom unrelated to my MS. They just experience stuff. And we as clinicians, I feel like, are going to try to help to sort out what is causing that. And once we can find a cause, then we can help treat it. So my point here is I would certainly reach out and talk to my MS provider. So Kim writes, does pain in the neck and back relate to lesions and thinning of the myelin? So interestingly, no. Generally speaking, when you have back pain, it's not coming from spinal cord damage. Oftentimes it's coming from other things. And that has to do with the way the spinal cord is structured and the areas of the body that relate to it. So when I hear about low back pain or hip pain or upper back pain, I'm generally not thinking about the spinal cord. I'm thinking about the muscles and the nerves that come out of the spinal cord, and I'm thinking about the bones and a bunch of other things. So let's see, we've been online for 34 minutes. There's 127 people still online. This is really awesome. I hope that you guys are enjoying this. If so, make sure to give it a like. So Tracy from Scottsdale says, howdy, Dr. B. Tracy here from Roanoke, Virginia, PA. Specializes in, ooh, I missed the question. Guys, this is jumping around. I'm terribly sorry. I need a question reader helper. Let me try again. So Michael Griffin writes in, and I'm trying to like highlight the question so I don't lose it for you guys. Have you seen many people with MS and Meniere's disease? I have both. I haven't seen many people, but I have seen that. And in the words of my late mentor, Omar Khan, sometimes nature is a little too generous. And you can have MS and another condition like Meniere's. So I'm sorry to hear that. All right. So CCal26 writes, can an MS hug feel like a sharp stabbing in your chest or feel as if you can't breathe for 10 to 30 seconds? I have heard it described that way, but of course you want to make sure that you get it checked out because other things can make you feel like you're being stabbed in the chest. But to answer your question directly, yes, that is possible. I have heard that before. So Dark Band writes, can you explain injection fatigue? So injection fatigue doesn't mean you're tired. Injection fatigue is a term that we use when people are starting to become really, really tired of having to jab themselves with needles. So some patients never experience injection fatigue, but most do. And it might not happen for 10 or 15 years. But you can imagine that having to poke yourself with a needle either every day or every other day or once a week, over time, I don't mean over weeks to months, but I'm talking over years and years, can get really cumbersome. And what we notice is some people, they just really start to become bothered by it. They don't want to do it. Sometimes they skip their shots. They perseverate about it. They have to have other people do it. And when I hear about needle fatigue or injection fatigue, I want to change their medicine. Because in my clinical experience, if someone's having genuine needle fatigue, it's not going to be long before they may stop their drug. And so I want to be preemptive and then switch them to something that's not a shot. Hope that answered your question. So Michelle Charles writes, is it true that if people have MS, they're more likely to develop other autoimmune disorders? Yes. If you have one autoimmune disease, you're at slight increased risk of having a second autoimmune disease. And if you have an autoimmune disease, people in your family are more likely to have an autoimmune disease. It doesn't need to be the same one. So that is true. And I think that makes sense when I think about it. You have a set of genes which may predispose you for autoimmunity because of the way that your immune system is constructed. And so it stands to reason that it may manifest in more than one way. I also remind you that if there's environmental factors, either for the individual or for the family, which might increase the risk to develop autoimmunity, you're going to be exposed to those environmental factors as you age. And so it may increase the risk further. It's not common, but yes, if you have MS, you're more likely to have a second autoimmune condition. When we diagnose people with MS, we check for other autoimmune conditions. We typically check for lupus and Sjogren's or rheumatoid arthritis and some other autoimmune conditions because of that exact fact. Okay. So Divine writes, Dr. Erin, I want to say thank you for all the content. You're welcome. You know, Divine, this is something that I feel passionate about. I want to try to impact as many people touched by MS as possible. I want to try to energize. I want to try to educate. I want to try to empower those people impacted by MS. And I try to do that in my clinic. I think that at Ohio Health, we're really committed to making patients and families the most awesome versions of them possible. And quite frankly, I'm very proud of the men and women I get to work with at Ohio Health because I think that we're really dedicated to this cause. But I think if I see 16 patients in a given clinic day, and I do a good job, that's 16 families that I hope I can help. But if I can jump online at 9 o'clock at night on a Monday evening during MS Awareness Month and talk to 137 people online, that's 137 families on right now. And maybe I can leave them with a pearl or with a nugget of MS education, which might make them have a better life, or it might help them have a conversation with their doctor, or it might sensitize them to something that they weren't thinking about before. And that really means a lot to me. I really appreciate you, and I appreciate this community. And I think it's awesome. And I love how we help each other. And so thank you for bringing that up. Now, Russell Hall is online. Hello, Russ. Do you see patients that are misdiagnosed with MS, and how common is that? Now, Russ, this does happen. We don't have a blood test to prove MS. And so instead we use a set of criteria. And the criteria are really good. There's 5 elements. Your story, that's your history, your exam, your neuro exam, MRIs, lumbar puncture, which you don't always need, and then proving it's nothing else. And if you apply the criteria, they're very accurate. They're not 100% accurate, but they're very, very accurate. But different neurologists may apply the criteria less well than others. And there are, independent from that, there are mimics of MS. There are things that look a lot like MS. And so it does happen for various reasons that someone is misdiagnosed. There's a paper that came out that said in an academic center, it may be upwards of 10%. And I certainly hope that's not the case most places. We take an MS diagnosis very, very seriously. And we want to diagnose you once. And if that means that we're not ready to provide a diagnosis just yet, and we want to get a second set of MRIs or a third set of MRIs or a lumbar puncture to help us be certain, it's worth it. Because I tell people, I only want to diagnose you once, and if I do, I'm not going to undiagnose you. That being said, this can occur. And I think that we have to keep an open mind, and we have to be very, very diligent when applying the diagnostic criteria. We have to be thoughtful and make sure we don't miss things. The substrate we're talking about is someone's mom or someone's sister, someone's husband, the most important people in someone's life. And we have to take the diagnosis of MS very, very seriously. We have to make sure that we do diligence, that we do the right workup. We get MRIs that are the appropriate kind of MRI. We know how to read them properly. We send our spinal fluid to the appropriate lab. We take the time to elicit a history. That takes time, Russ. And we do a proper neurological testing, neurological examination. These are the things that I think that we're obligated to do so that we don't have a misdiagnosis. Tracy Scott writes in, howdy, Dr. B. Tracy here from Roanoke, Virginia, who specializes in MS. Thanks for all you do. Well, thank you very much. This is a great community, and I'm loved to be joined by you. This is good stuff. Let's do a couple more questions, and I'm probably going to wrap things up. Let's see. Delaney writes in, can you talk about the JC virus? I tested with a high positive, and it scares me. I also just started Ocrevus, and there's been a few cases of infection that's crossed the blood-brain barrier. Help. Delaney, I definitely want to help you. First of all, hello and good evening. Second of all, let's talk about this JC virus. Now, the John Cunningham virus, the JC virus, it affects or infects about half of adults over the age of 30. So about half of us have the virus and half of us don't. Under normal circumstances, with a normal immune system, we don't care. The human body just beats up on the JC virus all day, every day, and the JC virus never ever causes an infection, ever. However, under certain unique circumstances, the immune system is altered and the JC virus can mutate. The virus can mutate and go in the brain and attack you. And actually causes a demyelinating infection called PML, or progressive multifocal leukoencephalopathy. This is sometimes a fatal infection. And so that's very, very serious. Now, there are certain medications like certain types of chemo used in cancer that can increase someone's risk to develop PML. And in the MS space where we're talking, there's a drug called Tysabri. It's a really, really good drug, but it increases the risk for some people to get PML. And so I want to break this down for you. If you are JC virus negative, and there's a test for this, then you've never been exposed to the JC virus, and it doesn't matter what drug you're on, you can't get PML. That's like saying, I've never come in contact with HIV-tainted fluid, so I can't get AIDS. If you test JC virus positive and you're on certain drugs that can increase the risk, then there's a situation where you may be at risk of getting PML. And Tysabri is an example of that. If you're JC virus antibody positive and you're on Tysabri, there's a very small risk that you can get PML. But we know more than that. Now, when you get a JC virus, you can get what's called an optic density or a titer. It's like a level. And the Laney says that she had a high level. And so if you are JC virus antibody positive with a high level and you're on Tysabri, the risk of PML goes up. And so an example might be in the first year, if you're a high positive, your risk it's still low relatively, but like 1/100%. Now, that's a very small amount, but that's be the risk. If you were a low positive, it might be 1,000th%. And so those are really, really different numbers. So she says that she's a high positive and she's on Ocrevus. Now, there has never been a case to date of PML with someone on Ocrevus who wasn't previously on Tysabri. There's been a handful of cases, and these were people with MS that were JC virus positive. They were on Tysabri. They switched to Ocrevus, and then the PML was discovered. And so we can use this information to our advantage. When I transition someone off Tysabri, well, number one, I'm going to know their JC virus. And either way, even if they're positive or negative, I'm going to get an MRI. I'm going to get an MRI as we leave Tysabri and before we start the next drug. To me, that's one of the best ways of feeling confident that I'm not placing that person at risk. Now, in Europe, a lot of times when they leave Tysabri, they actually do a lumbar puncture, a spinal tap, and they look to prove that there's no JC virus in the spinal fluid. And so that's another technique. And I'll share that I very, very rarely find that necessary. Now, keep in mind here, Laney, that if you have been on Tysabri in the past and you're JC virus positive and you transition to Ocrevus, it doesn't mean gloom and doom. If you haven't had an MRI, that's the first step. Get an MRI and look at it. And there are features of PML in the MRI. And so you can ask your neurologist, say, hey, I'm nervous about this. Take a look at it and tell me what you think. But we're talking about very, very rare cases. And I wouldn't throw the baby out with the bathwater. Probabilistically, it's super low. Now, that doesn't mean that you shouldn't think about it, but I don't want you to get all spun up and worried about it because I think there's ways of checking into it with an MRI, and then there's a way of moving on. So I hope that helps, lady. Thank you for the question. There's 140 people online. I've got 74 thumbs up. I'm feeling really good, guys. Thank you very, very much. This has been a lot of fun. Let's take one more question. Michael Levine writes, your videos are great, especially since my wife was recently diagnosed. Is there a video that you can do or have done that will help a loved one support their loved one with MS? The things to watch for. So that's a great question. And thank you for the kind words and thank you for participating in this and writing in. It's wonderful to me that some of the videos on this channel could help someone who's newly diagnosed. And he points out something really important. You don't have MS by yourself. Now, guys, there's a reason I use hashtag #WeHaveMS. Because let's face it, Michael has MS with his wife. Now, she has the biologic condition, but he's experiencing this disease with her from the outside. He's what we call a care partner, or what I call a village member. And he's a very important village member. He's the spouse. And so I think that we have to recognize that, and we have to try to help educate, empower, and we have to help care providers and care partners. So I do have a video on my channel which talks about care providers. And I'll try to leave a link down in the description below. If you type in care partner into my channel, I think you'll find it. But I'll try to include a link. And I'm going to make a note of this because it's a really solid topic. And we should do something, particularly this month, MS Awareness Month, focused on care partners. So that'll be a focus the next time I jump online, either in the setting of another live stream or in the setting of one of my videos. Now, as I wrap up, when I started today, guys, I asked you all a question, and I want to pose it again. What do you think about doing a lot of live streams this month? Probably not an hour each, and probably not every day. But given that this is MS Awareness Month, is that something that you would dig, or do you think that it would get tiring after a while dealing with Erin answering questions like this? So please leave comments down in the section below. I'm going to go through and read all of them, and I would love to know your thoughts. So once again, my name's Erin Boster, and thank you all for joining in on this evening on the weekday. This is really cool being Monday. Thank you for participating. Thanks for learning with me. This is MS Awareness Month. And we as an MS community have an opportunity to help raise awareness. Keeping in mind that MS is an invisible syndrome. It's an invisible disease oftentimes. People can't see how bad things are going. I think that we can do a lot to help people understand. Until my next video or until my next live stream, this is Aaron Boster saying thank you and take care.